First of all, thank you very much, Dr. Vohra, for joining us. I think what we'll do is we'll just do some very brief introductions. So my name's Andy. I'm one of the managing directors at Prospectus. And I'm here actually from a spark of a conversation, colleagues connecting us with Vanessa, one of the fellow trustees of the Menopause Charity. For me, I'm really excited because it's a topic where I think so little is known about. And this webinar seminar is really a bit of a beginner's guide with a focus around mental health. And we'll be releasing this over Mental Health Awareness Week. And I'm here because it's a great opportunity for learning. But I also think men should be part of the conversation as well. And just a general housekeeping rule for the recording. My son is here, so any weird noises are all him, not me. But hopefully when he's a bit older, he won't need to do a beginner's guide around it. It'll just be ingrained in society. But yeah, that's me. And I'll let Jess introduce herself and then we'll come to you, Dr. Vohra.
Thanks, Andy. Hi, my name's Jess Stockford. I'm one of the associate directors at Prospectus, and I lead our board practice, which is non-executive roles, trustee roles, and other non-executive appointments. And I'm really interested because I often have conversations with people who talk about the way that menopause has affected their career adversely, either enduring kind of really challenging periods in their career, or even stepping away from some roles and opportunities because they felt they haven't they haven't been able to continue because they've had a really challenging experience. So I'm also somebody experiencing menopause myself, so I'm really and I've been very well supported by Prospectus, but I'm really interested in opening up the conversation more widely for employers, for employees, and for really thinking about it for people in different points of their careers. So thank you, Dr. Vohra.
Pleasure. Thank you for inviting me. It's a pleasure to be here. It's a real privilege to be able to pass on information and make a difference at the same time. So it's a joy to be here. I'm here on behalf of the Menopause Charity, which I'm fortunate enough to be having been involved in from grassroots, from registration to actually now kicking off next week when we're launched. I'm a trustee to the charity, and I'm going to talk about menopause with a slant on mental health, mainly because it's Mental Health Awareness coming up in May, and it's such a big, they go hand in hand really, and I'm going to illustrate that to you as I talk. I have lots of other roles, and for transparency, because this is not about me and my career, I just want to put this up to say I'm unable to give specific medical or menopause advice to people because I'm not their doctor. So it is really important, but I hope today gives you the tools to be able to go and seek that advice and help yourself and give you some really good signposting of what's available out there. I'm not Hermione Granger, but they are my roles. And they're all part-time, but they are a privilege to be able to do all these different things in education and satisfying different aspects of what the career I'm lucky enough to have, really. So it's a real privilege to be able to do it. I'm going to start off by talking about the importance of women's health. So this is really crucial to grasp because in some ways it's obvious, but in many reasons it's just not given enough attention. So hence we talk about why is it important? It's 50% of the population. Statistically, 47% of the workforce, and there's a huge amount of evidence that shows that women are the largest caregivers and exert the most influence on the future of our coming generations. So it's really important to look after them. This graph here is just really for illustration purposes to show that women see their GP a lot more between 15 and 60. And when we take out all other causes such as heart disease, diabetes, anything else, men and women follow the same line. But when we include reproductive needs or puberty, pregnancy and perimenopause, women see a GP 32% more than men. So there really is a need for this. And currently we're addressing puberty and pregnancy somewhat, but we're not addressing perimenopause and menopause very well at all, and that's where the charity aims to improve that outlet. Basically, the three challenges faced by women are really crucial. They're puberty, pregnancy, and perimenopause. Like I say, they all stem from hormonal fluctuation. So the hormones are basically having a little life of their own and doing what they do in a lovely way, but also in a chaotic way. So quite often thinking about it like that really gives women a platform or anyone who's in this situation with estrogen, I should say, estrogen deficiency, a platform to be able to seek help as to why they're feeling not as well as they could. And for clinicians, it's always important, or practitioners looking after women, to be able to differentiate symptoms by taking a good history. And the reason I'm talking about that to yourselves is because I'm going to give you some tips on what you can go back to clinicians, or I'll say doctors for simplicity, with, and how to go about getting some help in the right direction. The scale of the menopause problem is that it is on the actual curriculum for GP education. Being a GP educator, I know that, but it's very factually taught. It's not practically taught. It's like the difference between showing someone a kettle and a teacup and saying, there you go, you're now able to make brilliant tea, compared to showing them how to make the tea and then watching them make the tea and then giving them nice constructive feedback as they do it. It's just not done in the same way. So as women age longer, live longer, their life expectancy has gone up hugely. So in the 1900s, the average survival was around 45. So women often passed away before they hit the menopause and had to live through it. Now life expectancy is well into 90s. So you're spending half of your life in a menopausal state. And that's why it has such a large impact on all women in that situation. The symptoms start during perimenopause, and that is the time in which the chaotic hormone changes start, and that can be up to 7 years, and that's the median that we find. And I'll talk about what the difference between these terms is shortly, but it's really important to understand that patients often get caught up in, am I perimenopausal, am I menopausal? And what we want to emphasize is it really doesn't matter. What really is important is that you're estrogen deficient and having symptoms from that. So it's estrogen deficiency that is the problem, not whether you're perimenopausal or menopausal, because these are textbook terms that don't actually help that much. Statistics show us 90% of women have symptoms, but only 12% get help in the form of hormone replacement therapy. Now that's really crucial to acknowledge of how poor the care is currently, and it's really important that that's changed, and hence the come about of the Menopause Charity. 20% of women will leave their jobs due to symptoms, and we're really keen to liaise with employers and empower services so they cater for providing a working environment which is conducive to going through the menopause changes as well. That's 1 in 5 women leaving their job. And that's quite important because it's not accounting for those that make changes to their jobs, such as their working hours or working days. So, that's actually about completely stopping work. 66% of women are offered antidepressants instead of hormone replacement therapy. Now that's staggering because as I talk through, I will let you know about how poor the evidence is for that, and how ineffective it is as well. And the paper at the top is a study from last year which very clearly showed a very large health inequality in terms of menopause care for lower economic communities and people from ethnic groups. And it showed that you're 29% less likely to get HRT in more deprived areas than you are in more affluent areas. So we've got a larger issue here for our society to tackle. First is a recognition, secondly is trying to make it more equitable. Hormone replacement therapy for menopause has massive long-term benefits, and these include heart disease, osteoporosis, mental health, and dementia. I know we're focusing on mental health today, but it is really important to put mental health in the context of the rest of the health, because we can't really separate mind and body totally. They're completely connected. If somebody feels unwell, their mental health will suffer, and if someone is mentally unwell, their physical health will suffer. So there are long-term benefits that are really important. There are also short-term benefits, and to me, these are easy gains. These are really simple. So the reason they're important to state is if you want symptom control, if the woman needs help today, an improvement in quality of life today, then that is very readily doable and available. And then we need to bring down the barriers to that. So I'm going to elaborate a bit more on each of these stages as I go through, but I wanted to show you a short video that summarizes things really beautifully.
So the menopause, if you break down the word, meno is menstrual cycle, pause is stop. So it's actually a look back in time, retrospective diagnosis. So officially a woman isn't menopausal until she's not had a period for a year. What happens is women become perimenopausal. So peri is a medical term for around the time of. And what happens often is that hormones gradually reduce as the ovaries don't work quite as well. So then people experience menopausal symptoms and their periods change in nature or frequency. This can occur for many years, sometimes even a decade, and then periods stop. So for most women, the menopause is a natural process. Our eggs stop being produced by the ovaries, and with that, there's a decline in hormone function. But for some women, it becomes enforced on them. So they have their ovaries removed in an operation, or they might have a condition such as a cancer, and they have treatments such as chemotherapy or radiotherapy, which affects the way that their ovaries work. So the average age of the menopause in the UK is 51. But that means on average, women in their 40s become perimenopausal. But there's around 1 in 100 women under the age of 40 have an early menopause, 1 in 1,000 under the age of 30. So it's not an older person's condition, if you like. It's really important that people acknowledge and recognise the symptoms.
I like to include that video because it simply shows how widespread it is, and there's too much of I'm still having my periods so I can't be perimenopausal, and that's really the biggest group of women that struggle to get help. And why is it such a big impact on their body? And it's so much more than just menstruation, is because actually the term menopause just means meno, to stop. It's look back in time. But every cell in your body has estrogen receptors. So if we look beyond just the reproductive cycle, all of a body has estrogen receptors, and men have estrogen receptors too. They do have some estrogen, not as much as women, but they do have it. And likewise, women have testosterone. So estrogen receptors are in every cell. The estrogen particle fits like a lock in a key, and then the cell can go off and do its designed activity. So when they're not able to do this, they're not able to function as well. And our bodies are quite incredible. They keep compensating. So women will spend several years feeling not well and not quite 100% before symptoms start to really pervade their life and disable them really. And then they end up coming to have a huge body of symptoms, and there are about 47 to 50 symptoms recognized at the moment. And these are the frequent attending women, and again and again I will see them in clinic, but when I look through their records, they've been coming for years and things don't quite fit, and they're labeled as medically unexplained or fibromyalgia or other things, and actually this body of symptoms is all here. And the common ones are there: palpitations, hot flushes, skin changes, but the ones that don't get enough recognition is joint pain. Urinary change is a massive thing, vaginal symptoms of dryness, changes in the bleeding, and actually the psychological side, which is what we're going to talk about. And there's a huge impact on psychological status, from actual mood changes to memory changes to anxiety and to sleep exhaustion. So because there's estrogen receptors all over the body, this is all going on in every organ and widespread. And there's a huge variation in the symptoms as a result. Now, I can't see the chat, but I would like you to ask questions either now or towards the end if you need to, but you'll find that I'm answering them as we go along as well. So I wanted to show you another video which shows about variation in menopausal symptoms, and then we'll go on to talk about them in more detail.
So the average length of time for symptoms is around 7 years, but some women don't experience symptoms at all, or maybe very transiently. Other women I see and speak to have symptoms for decades. Symptoms really vary, and they can change within a person as well. So a lot of women experience night sweats and hot flushes, the vasomotor symptoms, but also a lot of women experience psychological symptoms, and these are often misdiagnosed as anxiety or depression. So symptoms such as low mood, poor memory, reduced concentration, anxiety, low self-esteem, feelings of loss of self-worth. A lot of women tell me that they just feel low, their zest for life has gone. Other women experience muscle and joint pains. Some women experience palpitations, lightheadedness, And then people can have migraines, headaches, they can notice differences to their hair or skin texture. Some women experience urinary symptoms, so such as recurrent urinary tract infections or passing urine more frequently. And then a lot of women experience symptoms related to vaginal dryness. So symptoms such as discomfort during intercourse, but also it can cause pain even sitting down or wearing underclothes. So symptoms can change. So some women might say, well, I've gone through the menopause, I'm not getting any flushes or sweats. But then they develop anxiety or they become socially withdrawn, or then they might experience some urinary symptoms or some vaginal irritation and think that's part of getting older rather than it being related to their menopause. And so it's very important that if women are experiencing any symptoms that may be related, then they seek help and get the right advice, because a lot of women are not putting together the pieces. They might have gone through their menopause and their period stopped 10, 20 years ago, but they're getting some symptoms.
So I think these are really useful at highlighting how important it is to put the jigsaw puzzles together. And particularly one of the things that often comes up is, well, it can't be menopause because I'm doing this, or I'm on an naproxen helps it. But there's no reason why it can't be two things happening at the same time. And there's no reason why you can't help one while investigating the other. And I think that's where we really want to change the way it hasn't been prioritized to manage menopausal symptoms and estrogen deficiency, because if it is prioritized, it will transform women's lives. It's transformation medicine. It will transform their working ability and environment. And even the hot flushes, though they're mocked sometimes, they are not harmless. So if you're having hot flushes for several years, they're associated with all those changes, increasing your cardiovascular risk, in your lipid profile, in your blood pressure, in insulin resistance, which predisposes to diabetes, an increase in inflammatory markers, and also reducing your skeletal strength and bone density, and also increasing your risk of depression via the changes in the brain and inflammatory changes. So those couple of years is just constant micro trauma to your body, and it's all adding up. But this is still going on if you are one of those 1 in 4 women who are not having hot flushes. It's just all about a spectrum of symptoms rather than being so black and white that you're either in it or you're not.
Is there an average length of time that women will start to experience these symptoms before they take action and then decide to investigate further, or is it quite varied?
Incredibly varied. I think it varies by communities and ethnic groups and populations and social status, and so many things impact it. And I think in our health system, it's relatively poor. It can be up to 10 years. They've been in those symptoms before they've actually sought help. But when you look back in time, because retroscopes are always great, you see that they have been coming for things, but the jigsaw puzzle hasn't been put together. So they may have been coming for tiredness, joint pains, and all those things. So increasing its mental health impact is because hot flushes and night sweats are the symptoms that we get talk about the most and hear the most, but actually the symptoms that are the most debilitating are the ones we can't see, and they can't be pinpointed. And it's always challenging to seek help for condition that you can't see. But one of the classic things I find is women who have had a fairly objective, controlled view on life in terms of anxiety or mood changes, and led independent lives in the ability to drive or catch a flight on their own, suddenly being unable to drive on the motorway, having a fear of traveling, having a fear of being in crowded places, and having new presentation anxiety. And it's coming out of nowhere. And we'll often see a cycle to this. So anxiety, low mood, being panic or having panic attacks and being tearful leads to a massive loss of self and independence, and a fear of driving is incredibly common. So avoiding the motorway and just having a lot of anxiety. Many women will give up driving, and that's how debilitating it is. So it's a profound impact on their life. The anxiety leads to a change in their home life as well as their work life. They may avoid going out. They may start recurrently checking that they've locked things and closed things. And also it's a huge drop in self-esteem, and often leads to isolation. So if they haven't got that circle in terms of family or friends that they can be very open about, or they choose not to, they do end up having a degree of isolation, which makes seeking help that much more challenging. Mood swings, anger and irritability are really common. And that's a horrible vicious cycle, because the mood swings come, there's a degree of no control over what you say or do, and that leads to a vicious cycle of guilt. And also, you know, I've heard women say, I look in the mirror and I don't recognize the person I see. You know, I've just shouted at my children, had a massive row, and it was over something so small. And a few minutes later, I'm thinking, what was that about? And that's quite a horrible situation to be in repeatedly. And alongside that, I'd probably say fairly frequently, there's negative thoughts of self-harm and suicide. And I think it's when you get into that degree of impact, we have to seek improving the access that we have to help. I mean, I've seen a few women over my time that have been suicidal, and it's incredibly sad, because they really are stuck with in the situation that they're in, and it takes that much longer to get them to seek help. Chest pains, palpitations and panic attacks are incredibly common. I did a lot of work in A&E when I was newly qualified. I've been a GP for nearly 20 years, but before that. And I often saw women in the middle of the night with chest pains and palpitations, and our role was to rule out any sort of emergency cause related to their heart and then send them on their way. But we weren't trained, and never did we signpost thinking, could this be menopause? And that led to a huge amount of over-investigation, over-labelling and over-medicalisation. They end up on medication that has very little evidence and will not help. Sleep deprivation is huge because of the way estrogen deficiency affects the brain, as well as progesterone, which is the other hormone involved, and testosterone. So all three of them not being as present leads to exhaustion, which feeds this dopamine and sugar dependent cycle of overeating and tiredness. So you go for quick gains, which is have a snack because it gives you a little short-lived high, and then you drop again. So, you know, your mood is pretty much doing this. And also because of vaginal dryness, there can be frequent waking up at night. And, you know, this is very frequent. You know, it's up to a dozen times a night. And you can think about the sleep quality there. And, you know, I recently saw somebody who'd woken up about 5 times a night, and 2 months into having HRT, she was sleeping 7.5 hours in solid deep sleep. And that's a huge amount of exhaustion related. Joint pain is incredibly common. Chronic joint pain, you know, feels like your body's creaking. Women will lie in bed saying, I want to get up, but I can't. And often that gets misinvestigated or treated like joint disease such as arthritis. But it also leads to inability to exercise, which again deteriorates your health that much more, and also reduced ability to look after yourself. Encompassed within mental health is also loss of libido. That's very much related to the hormones, primarily testosterone as well, which is a female hormone made 90% by the ovaries. So as they've lost their function, the loss of testosterone leads to a drop in libido. And this leads to quite a lot of pressure for a lot of relationships and can lead to conflict, as well as a change in how women might perceive their own body and how they may feel in themselves. So it's a really important factor. And I think that obviously libido is a complex issue with lots of factors, but when you're going through this and if you're not getting the help, libido can be a very big impact from the lack of hormones. I've talked about brain health a few times. I want to spend a little bit of time saying, why is it so important? And why do you get all these changes with anxiety and concentration difficulties and low mood? So the lack of estrogen means that the receptors in the brain, in the grey matter, which is your faster acting processor of your brain, cannot work. So that leads to forgetfulness, you know, losing my keys, losing my car in the car park, those sorts of things that you often may laugh off for a few years. Brain fog, an inability to think clearly or think simultaneously. So many women will say, I just cannot multitask anymore. And that's often an indicator of that. And also the brain area that controls your body temperature is impacted, hence the hot flushes and night sweats. So the lack of estrogen causes negative changes, which we can call plaques in the brain. And they are slowly building up over the time that the lack of estrogen is there. There's very limited research on female brains for lots of ethical reasons, which can be argued, but probably not today. But when they have done research, they've found that those plaque formations begin in perimenopause. But what we recognize as dementia, and Alzheimer's being the commonest form of dementia, starts in midlife around the perimenopause. But the symptoms, which is what we recognize as dementia clinically, develop much later. So the brain continues to compensate, and you continue to muddle through without estrogen as long as you can, but possibly in the 70s and 80s, when dementia presents itself, that's when it gets diagnosed. So it's not a disease of old age. It's actually beginning to form much earlier. And women are affected by dementia twice more than men. And there's a doctor called Lisa Mosconi who's done a huge amount of research and publication on this. In the XX Brain is her book. And her research shows a woman who's 60 is twice as likely to develop Alzheimer's than she is to develop breast cancer. So, you know, we talk about all the brain changes, but in the spectrum of this has to be that the anxiety, the panic attacks, and the low mood is it's not just short-lived, it's having longer impact on the brain health. And that's all down to lack of estrogen. I mentioned heart disease. So the lining of the arteries has a non-stick surface. Think of it like a non-stick frying pan, and estrogen's involved in keeping that nice and shiny and clean. When you don't have it, it gets sticky and debris in the blood sticks to it. So you get an increase in your risk of heart disease in plaque formation. And when you take hormone replacement therapy, you get a 60% reduction. So it's really important to look at the long-term benefits as well. It is important, of course, to consider lifestyle. So smoking, alcohol, weight control, and exercise are all very important. By no means am I saying they're not, but it's really important to think about how our arterial health moves forward. Bone health is something that's always talked about. Women often come in saying, I'm concerned because of the family history of thinning of the bones. All women will have a gradual loss in bone density from the age of 30. And you'll see that they have more tendency to get fractures easily, and osteoporosis is affecting 1/3 of women over the age of 50. So you can see here what's happening. Normal bone is nicely rich and complex, whereas bone with osteoporosis starts to get very weak in structure, and hence the increased fracture risk. The predecessor to osteoporosis is osteopenia, which is thinning of the bones, so somewhere in between the two. 1 in 3 women will have osteoporosis by the age of 80, and hormone replacement therapy will reduce this risk by 70%. So it's really incredibly important to look at lifestyle in terms of not smoking, weight-bearing exercise, vitamin D and calcium, and alcohol intake. But actually, it's very important to acknowledge the benefit hormone replacement therapy can have on your skeleton's health. And it's really, really a game changer. And there's actually evidence to show that when you have osteopenia, which is one stage before osteoporosis, women who have been on HRT for 5 years, their bones revert back to being normal and healthy. So it is really, really important for bone health. So I've mentioned hormone replacement therapy a few times. What is it? It basically means you're replacing the hormones which are missing, and that is estrogen, progesterone if you have a womb, and testosterone if you need to. So we go in that order of replacing the hormones, and that improves the symptoms, and that is the whole set of 50 symptoms. And that's why we talk about it as transformational medicine. There's no other drug available that giving will actually change that. And if we relate it to somebody having low thyroid function, so hypothyroidism or a thyroxine deficiency, doctors will quite easily straight away give the hormone out. Same with diabetes, you know, you get treatment with medication or insulin because that's what needs replacing. So in the same context, what needs replacing here is the missing hormones, and when you replace them, you improve the symptoms. So today and life currently gets a lot better, but you also reduce the risk of heart disease, diabetes, osteoporosis, dementia, and all those mental health problems. And if we look at improving health span, so the quality of life as well as the lifespan, there is actually a huge amount of merit in using hormone replacement therapy. The benefits of it certainly outweigh the risks for the vast majority of women by far. So it is a real life-changing treatment, and there's lots of evidence to show that HRT used for up to 18 years definitely before then as well, but it's safe and it will reduce the risk of death from all causes, including cancer. So there's a huge amount of fear about HRT, which has been fueled by misconceptions of risks that it poses and breast cancer. And it stems from quite a long way back, probably about 2 decades, when there was a study called the WHI study, which had lots of flaws in it. And we're recognizing this now because it's been represented again and again. But they were older women. They were women in their 60s. So when they were given HRT and they went on to have heart attacks or strokes, all that plaque formation had already taken place for 10 to 15 years. So the strokes were not a consequence of having HRT, they were a consequence of being the age they are and not having HRT. So it's really important to take that on board. And avoiding HRT doesn't mean you won't get those same risks that come with aging or lifestyle or genetics already. They also had the use of older HRTs, which were either animal derived or synthetic, and we now have much safer body identical HRTs, which are the exact molecular component that women might have had when they were younger, and they don't actually pose nowhere near as many risks. And there's also a risk of lifestyle more than HRT. So for women in that trial group, when they were restudied, their lifestyle of smoking, alcohol, or lack of exercise, and by alcohol, it's even drinking 2 units a night, is associated with an increased risk of breast cancer. So they had much more changes to consider than just age and HRT. So they didn't account for their confounders that well. So all these things fuel the fears, but we need to work towards explaining it like missing hormones and replacing those, because it improves quality of life so much. There's a lot of talk about alternatives to HRT, because we all, I think as an advocate, we come across quite HRT heavy in terms of what we promise, but actually there's a lot of products available for menopausal symptoms, from herbal to creams to body identical, being labeled the wrong way, a bit like how you would go and get your foundation made up. People buy creams that have the right mixture of, one may go and get their foundation made up, not everybody, but creams made up with the right balance of hormones. There's no evidence for that. The thing with hormone replacement therapy in this country is that it's all been tested, it's approved by the MHRA, it's all safe for prescribing. It's far safer than buying something over the internet or taking a herbal product. There's very little supporting evidence for any of the alternatives. So the difference is from a fear of hormones to taking something with no evidence, with no regulation, and very little support that it actually helps. It's a no-brainer to actually go for the evidence-based one that's had the trials done. There's a guidance called the NICE guidance, which is produced for every topic or disease area in the health system from the National Institute of Clinical Excellence. And antidepressants are given to 66% of women statistically. But what they suggest is antidepressants, and venlafaxine is one of those, can be offered to women who cannot take HRT because they can sometimes reduce hot flushes and night sweats. So there is a group of women who maybe at that stage cannot take HRT, whether they're undergoing breast cancer treatment or awaiting outcomes of results. For them, yes, antidepressants may be useful, but they're definitely saying it's HRT first and then antidepressants as an alternative. Sadly, what we're finding in clinical practice is many doctors or prescribers are reverting to antidepressants first, despite we knowing there's evidence that they do not help the night sweats or hot flushes, but also there's very little proof that they actually help the low mood associated with perimenopause or menopause. So they have no benefit at all for the vast majority of women. So it seems like a real body of mistreatment to go on prescribing and taking that while suffering at the same time. So what can you do? This picture is taken from, it's not all doom and gloom, because we're going to change this and we're going to work away at it. So this picture is taken away from the Balance app, which is a free app, and it's incredible in terms of the the society, it's grown. I think it's reached over 100,000 users now since I wrote the slide, and it's got a community chat room, it's got information, it's got support groups. It was founded by Louise Newson, who is the founder of the charity as well, and currently campaigning to make menopause more recognised. So before you go and see a doctor, yes, they're incredibly busy, but this is your priority. It's making you feel unwell today. Stop and think about how it's making you feel. Write down, when was your last period? These are the things that you can prepare beforehand. When did you think your cycle started to change? Do you have a cycle of symptoms? By that I mean is, do you have 2 weeks of the month where you're quite functional, then 2 weeks of the month where you feel like you've been hit by a bus? That seems to suggest that the hormones are dropping in the middle of your cycle. There's a scale called the Green Climateric Scale, which you can use. It's got a bit of an old-fashioned name, but it's still very good. It's a symptom checklist for those who don't want to use an app. You can print it off and you can review yourself. So it's a really good way of correlating your symptoms. So I'll say to many women who aren't app keen, start your treatment and in 2 months' time, tick the boxes that you still feel, because it's only when they start to feel better, they have an appreciation of how rubbish they have been feeling. So it's a really good way to have a look at it. And obviously journaling can be another way. It's whatever works for you. But to go in slightly prepared is really helpful. And the app is incredible in terms of giving you background information. I'm going to leave this case study here. I won't go through it, but I'll leave it here because I wanted to highlight just how transformational it can be. So please, when it is available for recording, take a look. And I'd encourage you to mirror this. So if you go and see somebody and they give you HRT, go back at 6 months for a review and take it from there. There's a phrase, you might have to kiss a few frogs before you find Prince Charming. That's really important to take into account. It's really difficult when someone comes in to give them the perfect treatment for them straight away. Sometimes you have to try a few. That doesn't mean it's not right for you. It means one size doesn't fit all. We're on a spectrum. HRT doesn't cause breast cancer. Breast cancer is an age-related, genetically predisposed and a lifestyle-dependent disease. So if you're doing everything in your lifestyle to reduce your risk, which is not smoking, not drinking alcohol regularly, exercising, and maintaining your weight, then you are already doing huge amounts of reduction in your breast cancer risk. HRT has incredible benefits for your heart, brain, and your bone. And I hope I've highlighted to you that it outweighs those benefits against the risks heavily. Minor bleeding is really common when you first start, and expect that for the first 3 months, but any bleeding for longer than 2 weeks should be reviewed. When you take it via your skin, we call that transdermal. That has no additional clot risk. And I constantly see women who've had a miscarriage that was possibly down to a bleeding change or a clotting change, and they're told they can't have HRT. They can have HRT via their skin. If we use body identical hormones, carries minimal side effects for women. And if you have premature ovarian insufficiency, which is that 1 in 100 women who's under 40, which is actually quite common, then you should get specialist advice and care and not be left. You should be getting treatment at 40 until the age of 51 at least. And if you have an early menopause, which means you're under the age of 45, you should start and get treatment until the age of 51. And if we just mop up that group of women, we could improve their quality of life and their impact on their wider community hugely. 2 to 5 years will control most women's symptoms, but there's no arbitrary cutoff to stop. And we have to balance benefits against risks. And I feel quite passionate about this. There's no other medication that you start and never see the person again. So, even with thyroxine, which there's evidence to say you don't need a thyroid blood test apart from every 5 years, people are still given an annual blood check. So you should be given an annual review. And HRT can be continued long-term if you're under 60 or within 10 years of the menopause, or if you choose to and you're using body identical hormones. But I do think it's really important that we as preventative medicine start thinking about health span, improving the quality of life, because we know when people have a better quality of life, they live longer. And menopause is the biggest black hole in the NHS. So as a charity, we'd like to change that and transform the lives of women. So I just wanted to finish by saying this is a programme that's on next week. It's we're fortunate at the charity to have incredible ambassadors who are giving up their time and efforts to support us. And Davina McCall's done this programme, which is the first of its kind to be this frank. And it's on next week. I really encourage, if you can, take a look at it. But aside from that, if you are able to support the charity, help us change lives, either by donating, following, or visiting the website, because it will go live next week after the programme. So that's me. Thank you very much.
Amazing, thank you.
Dr. Vohra, so I've just been scribbling away. I hope it was as useful for everyone involved as it has been for me personally, and I know that we're going to hopefully put this live as well. I have a long-standing appointment that I need to jump off onto at 12 o'clock, but I wanted to I know that Andy will be my is going to be asking lots of questions that I've primed him for, and I know that colleagues will have questions too. But thank you so much, and good luck with the rest of the crowdfunding. And looking forward to seeing how the charity develops, and yeah, let us know if we can support with that. Thank you.
Thank you so much. Thank you.
Thanks all. Bye-bye.
Cheers, Jess. What I will do, if that's all right, there's a question that Jess has popped through.
Yeah.
And feel free to, if you want to see sort of faces and stuff too, you can take down slides and whatnot. But I think Jess's question was actually, what can employers do? Do you think, in your view, to support women sort of be menopause friendly, whatever the term might be?
I think there's lots of things that employers can do, and it's changing if we change it, it's not only them though. I think employees can do things as well. I think there's a degree of openness and awareness increase that will help. It's a simple change in terms of making it more talked about. And so, women feel more able to raise it, because it is incredibly debilitating. It's been put on par as some disabilities like psoriasis or epilepsy in terms of same life impact. So there can be things like the temperature in the office, provision of breaks or fans. And again, if someone is not, and I think having an open door policy to come about it is a massive thing, to have an approachability and a non-mocking kind culture will make a huge difference in terms of how people come forward. In future, the best thing would be that it's part of occupational health. So if they're able to start that in conversation early, we struggle at the moment because it's not recognised as a health entity enough. So, if we come to look at screening or health checks or insurance, medical insurance through work, menopause isn't recognised on there. So we have barriers to overcome. But if occupational health could start talking about that, I think that's really important, because for some women, they may not recognise it themselves. And if it's raised for them, it might help. And starting the journey like that would probably be the best way forward. I think the ultimate aim would be to have work amendments made as well. So some women aren't able to get that flexibility of having a change in their working routine. If that's accommodated, you're investing in your employer moving forward.
Okay, cool. I think what I'll do is, I do have more questions, but I'm conscious there's quite a few people on the call. I want, are we able to get any sort of questions into the chat, or Chris?
Yeah, sure.
Who is the man behind the scenes making it work? Are you able to open up the room at all so more people can join the call?
Yeah, I can see a comment from Peter, but I can't see the questions. So Peter's written, not a question but a comment, highly informative and important. I recall my mum having all sorts of issues and challenges in the 90s with menopause and not having the right support. Yeah, and my dad and my brothers, so important. Yeah, absolutely. Saying, if you totally agree with you, Peter. Thank you for that. And it's really nice to have representation from all sides on this call, because we're really keen to make it everyone's issue. It's a bit like safeguarding. It needs to be everyone's issue, for it to keep cascading and moving forwards. And as we change to a more cohesive approach towards it, if it's included in health, sex education at school and health education at school, the generations moving forward will just naturally accept that it's part of life. And with an aging population, that's what we really want.
Emma?
Can you hear me?
Yes.
We can
Hi.
hear you.
Yeah, if anybody
can see me.
else has any questions,
Oh.
yeah, if anybody has any questions, please just pop your name in the Q&A as Emma has done, and I will unmute you so you can be part of it.
Okay, shall I go?
Yeah.
Thank you. That was so interesting and so important. I feel like I've learned a lot, and particularly around the mental health side of things. I have to admit, I had no idea that I can understand how it's closely linked, but actually to hear about it is fascinating, and a little scary, I would say, as well, a little daunting. But my question was about whether the charity will be doing any work around, I suppose, some of the language that's used. You touched on it just now, I think, but some of the language that's used, or some of the throwaway comments that are made. And I'm thinking about it in terms of from an employment point of view, I suppose, but you know, those comments that people make, she's just going through the change, you know, those kinds of things. Will there be any kind of work done around that? And then, you know, it'd be interesting to know how we could support that, I suppose.
Yeah, there is work going around that. I think we can't, we have to use the M word, and menopause has to be part of it because it's so ingrained. But what we're trying to do is make it much more positive and much more proactive. So own your menopause is part of the hashtag that we're going to use. I think as the culture changes around it, like it has around many areas that used to have throwaway comments that we now know are not politically acceptable, hopefully that's the direction we will go in. The charity definitely wants to campaign and lobby towards more equitability in every sector, and that. But the challenge is making the information relevant to the women themselves, the employers, the family, the governing bodies, and so we're trying to face that at the same time. So definitely aware of that.
Great, thank you.
And then we've got Kieran feeling equipped to go back to the GP.
Yeah, I was just going to add, Emma, one of the things. Sorry, I just add to Emma. One of the things I always say to women, though, when I do much more when I used to do face-to-face talks, you just reminded me, is challenge it.
Yeah.
You know, one of the biggest things is if someone says to you, it's just the change, just go, well, actually, it's not.
Yeah.
Talk, and this is what it's about. It's a deficiency of hormones. And I think that's really important, because if you don't challenge it, you're reinforcing that statement. So I would say, you know, it's a hormone deficiency. Have you heard of low thyroid, diabetes? They're hormone deficiencies.
Right.
That's what this is. And I think that's a really important thing to send the message out there and empower women to be able to challenge it.
Yeah, no, definitely. Thank you.
I think that really resonates with Kieran's point about too often women are told it's just part of life and to get on with it. Yeah. So definitely dovetails with that message about challenging. I think Camille has a question.
Hi, Radhika.
Hi.
Can you hear me? Hello. Yeah. Oh, thank you so much. Really, really interesting. Really enjoyed it. And I just wanted to ask kind of whether or not there is kind of like an evolutionary reason for the menopause, in your opinion, or whether that has kind of just really come about since women are living longer.
Yep. Really important question. So the history of it is that in the 1900s, like I was saying, you survived about mid-40s. We were designed to have far more babies, breastfeed longer, and we've modernized medicine and society quicker than our bodies have adapted. So what we're finding is girls are starting periods earlier, probably on average 2-3 earlier in the last 2 years earlier than in the last 2 decades than they used to, and going through menopause earlier. So because medicine has advanced our longevity so much in terms of treatments available, we're spending longer in this menopausal state. So it's always existed. But I think when I qualified 20 years ago, lifespan was about 65. And now it's not uncommon to live to 100. So we've done huge progress in the last 20 years or so, but we haven't progressed in addressing women in this state as well. And if we just addressed it simply by estrogen replacement, they would have the same quality of life. But there's an expectation to perform and professionally, in family and physically in the same bar as other counterparts like men, but without the hormones, and that's unrealistic. And I think also what we also find is women get so many women will hide how they feel because they feel embarrassed about it. And that's one of the things that we want to change from awareness is actually, this is reality. It happens to every woman globally who lives to the age of 50. It's going to happen. And if we just normalize it like puberty and pregnancy, then we don't have to have a taboo associated with it.
Absolutely. So important. Thank you.
Anna's asked, that's a really interesting question actually. I hadn't considered that. We'll bring Anna in to ask that. Feels more fun bringing people in for the variety of voices.
Hello, can you hear me?
Yes, hi.
Hi, Dr. Vohra, that was really, really good, really educational. I must admit, I'm pretty terrified right now, but it's very good to be talking about this and educating everyone. Slightly selfish question, but I think might actually be relevant to others as well. Do we know if symptoms of menopause are worse or better for women who have not had children?
There is, yeah, but there's more parts to it than that. So women who haven't had children, firstly, may have had contraception for contraceptive reasons. Yeah. So if you've had contraception, you've actually switched off your cycle, which is a good thing, because otherwise you've got your ovarian cycle running every month, and we're born with a certain number of eggs, but by the time you start menstruating, 3/4 of them are gone. So if you aren't running that cycle every month because you're on contraception, you're switching that off. So that has a positive impact. Switching off your cycle is a good thing. So for those women, their menopausal symptoms may come later, but lifestyle has a huge amount to do with it. So caffeine intake is a real trigger. Alcohol, exercise, endorphins all help with the brain pituitary access to your reproductive organs, and ovaries are included in that. Because effectively contraception does what pregnancy does, it switches off your cycle. Yeah. For women who haven't been able to conceive, and I think that's a really important group to look at, because there's a real secondary arm to infertility and how that's talked about in our society and workplaces, because it's not understood as well, and it's got lots of negative feelings associated with it. So for women who haven't been able to conceive, and that is a very big red flag that menopause might happen earlier.
Oh, right.
Yeah. So often, if I've seen women in clinic, and we all see this, those of us that work in menopause, they've had several cycles of IVF, not been able to conceive, but yet they're still suffering till the age of 50 plus, because that's the age they believe that they can seek help for menopause. But I know I see women much earlier, and whether they've had successful IVF or not is irrelevant, but if they haven't been able to conceive, that's a big flag that their estrogen levels were low.
That's really helpful to know, both sides actually. I choose not to have children, but I have a lot of friends who've gone through IVF, so just being able to be aware in advance for them, but reassuring. Thanks a lot. That's great.
And I think it's really important to think about it beyond your reproductive functions. It's all very on cue. It's all very nice to have children. Of course, it's for some people that's their function, but we need to start thinking about estrogen's wider functions for our body, just like we think about thyroxine and insulin. It's so widely important, and our main purpose for estrogen isn't just to reproduce, it's actually keeping us healthy. And that's what's really important for those women. And I think it's really tough for women who've struggled to conceive or gone through the process. And obviously the reason for infertility can be on both partners' sides, but I think it's really important for them to seek help. It's really important. And often they're quite broken by a system that they've been treated like a little bit of an apparatus in, for wanting a better term. So they should seek help for sure.
Thanks,
I think that's a really interesting point around the fertility. So the person interrupting the call is a product of IVF. And I think it's a really interesting point about people don't talk about it. And it does create, even if for example, fertility is one of the issues. It's just not talked about. And I can't recall them ever considering it could have been early onset menopause. Or something of that nature. It's really interesting, actually. So I think being able to have those conversations is so terribly important. Even some of the stuff you talked before about brain fog, people get labelled a lot with baby brain when they're pregnant, and it's talked about in a completely different vein and tone as opposed to menopause. It's almost kind of something positive rather than negative. Yeah, fascinating.
And as women have children older, it is 1 in 40, 1 in 100 women under 40. So, and 1 in 1,000 under 30. So these are really common things. And, you know, there's diseases that are far rarer that are given a lot of attention, you know, and this is not given enough attention. And I think that we need to start talking about it more. And what we know that there's enough evidence about in social studies is if we talk about the uncomfortable, it becomes comfortable. And then we look for solutions for it. So if we don't talk about it, and there's really no reason for it to be uncomfortable. I think it's all about, when my teenage boys talk about it, they're just used to it. It's what we do. So, you know, it's all about normalizing it.
Cool. I think we're actually coming up to, and I can't see other questions in the chat. We're coming up to 12:15. I think I'd just like to say thank you so much for taking the time out of what I'm sure is a busy day, and we still have, I think, pretty much everyone that started on this call sort of has stayed, and I hope enjoyed it. I certainly have, and I think I'd encourage anyone to go and check out the Menopause Charity. It's really interesting, and every time I speak to anyone from that organisation, I learn so much more. Yeah, so I just want to say thank you very much. It's really, really appreciated.
Oh, my pleasure. Thank you for everyone who's come, and thank you for all your questions and engagement. You know, it's really nice to have, there's a butterfly effect of everyone you speak to, and that's really important, because if we're going to change things on a wider span, that's what we need to be doing. And the more we talk about it in our home settings, in our families, in our workplaces, in offices, the more normal it becomes. And then I think awareness will feed demand, which will feed a need, and the professionals will have to listen. Because if everyone's there, they're not going to, you know, it's just not sustainable to keep turning women away. So if you are one of those women who has symptoms and you've been noticing them but don't feel you've been listened to, please do go back, use the app, collect the information, and go back prepared, and don't take no for an answer, because you can certainly be helped. I always say to women, ask a very clear question: where is the evidence that I cannot have HRT?
I think that's a perfect note to end on. I think that challenge, right?
Thank you very much. Thanks a lot.
Thank you very much.
Bye-bye. Bye.
Bye.